is going to be about pediatric obesity.
Recording in progress.
طيب, the objective of this presentation is going to cover the following point. There's some sort of introduction, epidemiology of obesity, diagnosis, how we diagnose it, cause and risk factor, obesity comorbidity, obesity assessment, and treatment, prevention, and one slide about metabolic syndrome. So epidemiology, pediatric obesity is an exponentially growing global public health concern. United States, children and adolescents aged 2 to 19 years in 2017, 2021, according to CDC, the prevalence of obesity was 19.7 and affected about 14.7 million children and adolescents. Obesity prevalence was 12.7 among 2 to 5 years old, 20.7 among 6 to 11 years, and almost 22.2 among 12 to 19 years. And you see very clearly that adolescents are more affected. And not only that, even 2 to 5 years old, even us at our clinic, we see a lot of kids, they're 2 to 5 years, they're having obesity. In 2019, estimated 38 million children under the age of 5 were overweight or obese. Overweight or obesity are now on the rise in the low and middle income countries. طبعا يعني it is a real problems, particularly in urban setting. In Africa, the number of overweight children under 5 has increased by nearly 24% since 2000. يعني الناس بتفتكر in Africa only we have the issue of malnutrition, but again the obesity is a real problem. طيب, I searched in the literature looking for the obesity prevalence in Sudan. I found one of the studies done in 2012. The other study is very small sample size. This is a study done in 2012. School children at Al-Khartoum. Almost they investigate 1,138. They find that the obesity is around 9 and overweight is around 10.8. Like body mass index, it is a measure of the body weight adjusted for height. It's a useful tool to assess body fat. Body mass index is defined as the weight in kilogram divided by square of height in meter. A body mass index that plot in appropriate gross chart is a method to diagnose overweight or obesity in children and adolescents their age 2 years and above. And the body mass index level correlate with the body fat and concurrent health risks, especially cardiovascular risk, and it predicts future obesity as well as morbidity from obesity. Like how we diagnose obesity, what are the criteria we use? If you look for these weight categories, as we know, if the child weight body mass index is below the 5th percentile, this is an underweight child. And if the child body mass index between 5/5 and 85th, this is a normal child. And if between 85th and less than 95th percentile, this is overweight. And if the body mass index above the 95th percentile or above, this is obesity. And there is recent classifications, a body mass index of 120 or more and less than 140 of 95th percentile. That means a body mass index of 35 kg per meter square. This is classified as class 2 obesity, and class 3 if the body mass index is 40 or more kilogram per meter square. And this is recent classification. It is clinical practice use when we are talking about the medications and pediatric setting. So if I have a 10 years old child and his body mass index is here in this area, so the child is obese, and if it's in yellow area, he's an overweight, and if it's in green area, this is a normal child, and if below that, this is an underweight child. For children their age less than 2 years of age, be diagnosed as obese if the sex-specific weight for recombinant links is 97.7 or more percentile on the World Health Organization chart. And if you look for the equation 97.7, it is equal to 2 Z-score. And if you see this is the gross chart of the WHO weight for links. And if the child weight for links like this is above the 2 Z-score, that means the child is having obesity. And why it's of concern? Because as I mentioned before, currently we see children even in age less than 2 years and they have obesity. So you have to know which centile and which cross chart we are going to plot on. Like the cause of obesity, the common cause, as all of us we know, it is an environmental factor, or we call it exogenous obesity. So the current eating habits, people currently they eat more fast food, more sweet beverage with less fruit and vegetables. And again, the physical activity and sedentary behaviors that promote energy imbalance. Currently, we saw a lot of children, or almost most of our children, they spend a lot of time in the screen time, digital games, tabs, telephones, and others, and less hour on the physical activity. The rare causes is monogenic obesity. This is a single gene defect, namely MC4 receptor deficiency, BOMC deficiency, leptin deficiency, leptin receptor deficiency, or obesity associated with certain syndrome like Prader-Willi syndrome, Bardet-Biedl syndromes, and endocrine causes, Cushing, hypothalamic lesions. Again, this is all is a rare cause, but as endocrinologists, commonly we see children in our clinic who are obese because people they think most likely is having an endocrine issue, but really it is rare. But we have, as for you, you have to know what other cause rather than the exogenous obesity. You have to think of it. The comorbidity of pediatric obesity, as we know, the pediatric obesity can cause a lot of problems, affecting many systems psychologically, pulmonary, gastrointestinal, renal, musculoskeletal, endocrines, cardiovascular, neurological, and endocrine, mainly type 2 diabetes, or sometimes they have precocious puberty, premature puberty, peripheral one, and polycystic ovary syndrome with hypogonadism in children who's having another problem. So all the system is going to be affected, and this is why currently we are talking about pediatric obesity because of this possible complication if we are not interfere early. Assessment of obese child, how we assess obese child. So if you come across obese child, how we are going to tackle the problem of this child. The most important thing when you are assessing the obese child, you have to assess the medical risk, the behavior risk, and parent readiness to change. Medical risk, behavior risk, and parent readiness to change. Why the parent readiness to change? Because sometimes you offer the parent the information and something to do with their child who's obese, but the parents themselves they don't think their child is having problems. So this is very important. You have to check it. Type, what is the medical risk? What we mean by the medical risk? Risk of future or persistent obesity. If the child, his parent having obesity, so the risk of the child to have obesity or to have a persistent obesity to adulthood is very high. The other point, risk of future obesity related complication. If there is family history of type 2 diabetes, insulin resistant, childhood type 2 diabetes, cardiovascular disease, hypertension, hyperlipidemia in the family, so the risk of this child to develop obesity comorbidity is very high. A third point is identification of current obesity-related medical condition. And how we can identify that? By the following. You have to take history, looking for the complications, and you have to do examination, looking for the complications, and you do certain lab investigation for obesity comorbidity. So this is the medical risk. What is the behavior risk? The behavior risk, you have to ask about the current eating habits. The current eating habits, we mean fast food. How many times this child eat fast food? What about the sweet beverage? And what about fruit and vegetable? How many times he eats fruit? How many times he eats vegetables? So this is very important information because if you gather it at the beginning, so you can give good advice for the parent. Physical activity and sedentary behaviors that promote energy imbalance. Screen time. Really, currently we are starting obesity clinic in our hospital. One of the universal problems, the screen time. Kids is spending hours and hours, almost like 7, 8, 10 hours in screen time. When we say the screen time, we don't mean the academic activity screen time. No. Out of the academic activity screen time. Hour of physical activity, most of children, they are not spending any time of physical activity. So this is important information you have to gather at the beginning. Type evaluation in the history, you have to ask about the age of the onset when this obesity started. Why for? Because children who develop obesity before 5 years of age or as early as 2 years old, it can give you a clue to specific diagnosis, especially you have to put in your mind the syndromic obesity and the genetic obesity. Diet and eating behavior, as I mentioned, the behaviors, physical activity, school and social issue, because these children who have obesity is having an issue at the school. Sleep problems and daytime somnolence. This is again, it gives you clue to the complication of obesity, obstructive sleep apnea, symptoms suggestive of diabetes, any monetary irregularity, especially in adolescent girl, again, symptom of hypothyroidism, family history of obesity, as I mentioned, and family history of early heart disease. When you examine a child who is obese, you have to measure and plot the following. The height, why it's important, because if the child is obese and his height in the higher side, this is most likely you are dealing with exogenous obesity with very rare exceptions in MC4 receptors. But the common cause of obese child and his height in the higher side, the first impression, this is an exogenous obesity. And if the child is obese and his weight in the lower side, his height in the lower side, then you have to think of pathological issue. Again, the weight and the body mass index, the weight circumference, you have to check the blood pressure. It is very important. You have to look for the dysmorphic feature. You have to look for sign of Cushing, thyroid issue, a cancerous significance, sign of polycystic ovary syndromes, and you have to assess puberty. So this is the important point you have to look for. For sure, you look for musculoskeletal examination for any deformities. This is the important point in examination. So there is certain features suggest genetic syndrome or suggest a pathological issue. If the child is short, having severe unremitting obesity, and his obesity started very early, before 2 years of age, he's having some sort of dysmorphic features, he's having learning disability. If the child is more than that, having hypotonia, hypogonadism, skeletal abnormalities, other organ abnormalities, this can give you a clue. This child is not having just an exogenous obesity, he's having pathological problems, and you need to look for the cause. Investigation, when you come to investigations, you have to categorize your thought. You have to do investigation looking for the cause, and you have to do investigation looking for the comorbidity. Investigation looking for the cause, endocrine cause if there is clue. So it is not routinely we need to screen children who are obese for endocrine cause, doing thyroid function and other. No, if there is from the history and examination there is clue for endocrine cause, then you can check the endocrine cause. Consider the genetic testing. Certain group of children, especially those who are less than 5 years, of having obesity started very early with very rapid unremitting with special food-seeking behavior, then this group of children you can think of a genetic testing for them to exclude monogenic obesity. Investigation for comorbidity, it is very important to investigate for dysglycemia, pre-diabetes and diabetes, dyslipidemia, non-alcohol fatty liver disease, polycystic ovary syndromes, and don't forget to investigate for obstructive sleep apnea if there is history suggestive of that. So this is the investigation you need to do. If you are working, like in the situation in Sudan, you are working outside of the endocrine center in a rural hospital or hospital outside the, as I mentioned, the endocrine center. So there is certain indication for referral to secondary care. If from the history and the examination, there is possible secondary cause for the obesity, short stature, dysmorphic feature, learning difficulties, these children need to be referred for the higher center or secondary care on the endocrine center for further evaluation and investigation, and most likely they need multidisciplinary team. Presence of comorbidity, if the child is obese and having comorbidities, again, he needs to be referred for a center where there is a weight management clinic or a team that can deal with hypertension, disorder of eating, because those who have disorder of eating, poor body image, as we know, there is a lot of psychiatric problem related to obesity and anxiety, depression, eating disorder. This group of children, if you start to give them advice about decreasing the weight, you're not going to improve. So depression and anxiety, obstructive sleep apnea, orthopedic problems, okay, because if you don't treat the orthopedic problems, probably the child is not going to have physical activity. Biochemical evidence of dyslipidemia, impaired glucose tolerance, liver dysfunctions, and evidence of PCOS. So if you have any evidence of comorbidity, so you can refer the child to the center where they can deal with these problems. Treatment of children and adolescents with overweight and obesity. It composes of 4 stages. Usually you have 4 stages of treatment. And the stage, again, it depends on the age of the child, the body mass index of the child, and present or absence of the comorbidity. And the 4th thing is there any health risk, behavior risk, or medical risk? Management of obesity, in general, it needs teams. Doctors, health coach, dietitian, psychologist. And again, it needs the school, the community, all these people need to be involved in the management of obesity. Refer in obese child with possible secondary cause, secondary care, as I mentioned, and refer those with associated comorbidity specialist to specialist unit for a specific management. Lifestyle modification with motivational interviewing, this is very important intervention. So the stages, generally you have 4 stages: stage 1, stage 2, stage 3, and 4. So stage 1, this is usually 1 and 2, or 1 can be done at the level of the primary health care if you have a good primary health care, because usually we call it prevention plus, just promoting basic health lifestyle and improving activity and eating habits. Stage 2, if the child is not improving, you can move to stage 2. How usually we need around 3 to 6 months to move to the second stage, structural weight management, and usually this is done at the level of secondary care or sometimes at the level of the primary care if there is good setting. It is prevention plus increased support and structure, plan reinforcement with behavior therapy, motivation interviewing, monthly office visit, eat planning created by dietitian. The stage 3, it needs comprehensive multidisciplinary interventions, and this is usually done at the level of secondary care. And the stage 4 is a tertiary care intervention, only approved for adolescents, because this group of children, if they have certain criteria, they may need a pharmacological intervention, and if the pharmacological intervention not work, then you can think of bariatric surgery. So this is the stages of intervention for obese children. The most important is for treatment of childhood obesity: healthy eating, physical activity, limited screen time, increased fit time, and more sleep. The more sleep. And the most important, you have to memorize it, is a rule of 0125. What is the rule of 0125? A rule of 0215 is 0 sugary drink. 0 sugary drink, more water, 1 hour or more of physical activity, 2 hours or less of screen time out of academic activities, 5 or more fruit and vegetables per day. So the rule of 0125 is the golden rules. It is very important in the intervention plus, and it is very important in the prevention of obesity. So lifestyle modification, as I mentioned, must be intensive, age appropriate, culture and financial sensitive, and family centers. Family center, because if you talk about the family to the family, tell them their child have to do 1, 2, 3, 4, and the families themselves, they bring soda, they bring a lot of sweet and bring everything, and they tell the child, no, you don't eat because the doctor said you have to be avoided completely from this sweet beverage and from this fast food. So it must be family centers. financial sensitive، خاصه مثلا عندنا نحن الوضع في السودان، يعني ما تقدر تقول له والله انت اكل سمك واكل وهو اصلا ما قادر يشتري رغيف اصلا. فintensive age appropriate culture age, because the adolescent, as we know, we have a specific deal with the adolescent. So when we are talking about the lifestyle modification, as I mentioned, the diet, the physical activity, and behavior modifications. Dietary modification, what we mean by it, decreased consumption of fast food, add table sugar, high fructose corn, high fat, high sodium, processed food, eliminate of sugar sweetening beverage, increase consumption of whole fruit rather than fruit juice. People usually they drink rather than eat, but eat is better than drink. Increase intake of dietary fiber, fruit and vegetables, and encourage timely, regular meals and avoiding frequent snack. Portion control education is very important again. Physical activity, we need minimum of 20 minutes, and then you upgrade to the goal of 60 minutes. And you have to limit an non-academic screen time to 1 to 2 hours, as I mentioned, and decrease other sedentary behavior such as digital activities. وطبعا الآن كل بيت فوقه بلاي ستيشن، ودي واحدة من المشاكل. أي طفل عمره 5 سنوات عنده تلفون iPhone 13 Pro Max. طيب, the goal of the management is either weight maintenance or weight loss. So when you are dealing, what is the goal? The goal is either to maintain the weight of this child rather than to reduce the weight, or you need to reduce the weight. Maintaining the weight or reducing the weight, this is depend on the age of the child, the body mass index of the child, and the medical risk. So those who are adolescents with severe obesity, having medical risk, for sure we need to reduce their weight. And those children who are having overweight and their age less than 10 years, usually we need just to maintain their weight. And if we maintain their weight because they are growing, the body mass index is going to drop down. Type pharmacological therapy for children and adolescents with obesity, we offer only this after formal program of intensive lifestyle modification has failed to limit the weight gain or to ameliorate the comorbidities. And people are currently talking about children whose age 12 years or more with a body mass index of 95th percentile or more with comorbidities, or those whose body mass index is 30 kg per meter square without comorbidity. And there is a list of drugs. Some of them they are FDA approved for children, and some of them they are not FDA approved, and people they use it off label. So the FDA approved is orlistat, and all of you know the orlistat is one of the medication early on used for treatment of pediatric obesity. The problem of it is the GIT problems. The recent medication approved for treatment of pediatric obesity is the liraglutide, and the liraglutide one of the incretin hormones, and it is GLP-1 glucagon-like peptide. This is a recent one, and this is published. This is published on Endocrine Diabetes Obesity 2000 February recently. Type. So this is the medication, and as I mentioned, these medications only for children who have certain criteria and whose age is 12 years, and you do with them intensive lifestyle modification, but they fail to show any improvement. So you can try this medication. But the important point, the clinician must know it. The clinician should discontinue medication and reevaluate the patient if the patient does not have more than 4% reduction of body mass index. Body mass index is the score reduction after taking the anti-obesity medication for 12 weeks. That means 3 months at a medication full dose. So if you give the child the medications and you give the full dose with the lifestyle modification, but no improvement, so you have to move from this stage to the other stage. There is a lot of controversies regarding pediatric obesity, the indication, the criteria for pediatric obesity. This is in American Society of Pediatric Metabolic and Bariatric Surgery Guideline 2018. This is the latest one. Indication and contraindication for adolescent metabolic and bariatric surgery. Indication for adolescent include if the adolescent, his body mass index is 35 kg per meter square or 120 of the 95th percentile with clinical significant comorbidity condition such as obstructive sleep apnea, type 2 diabetes, liver issues, or the child is having body mass index of 40 or more kilogram per meter square. Again, this is another indication for bariatric surgery. So the child if the child having this criteria, and you try with him the lifestyle modification, and give him the medication, and there is no improvement, so you can offer them this bariatric surgery. But for sure, the bariatric surgery for pediatric, it needs to be done in a center with good volumes and good experience. There is certain contraindication for the adolescent pediatric surgery, a medically correctable cause of obesity. If a medical correctable cause of obesity, so this is you have to do it to correct it by the medical treatment. And ongoing substance abuse problems, medical, psychiatric, psychosocial, or cognitive conditions that prevent adherence to postoperative dietary and medication regimen, or current or planned pregnancy within 12 to 18 months. وطبعا ده واحدة من contraindications. So this is for a bariatric surgery. طيب, prevention, how we prevent obesity, health education program about lifestyle modification, diet, physical activity, behavior change, targeting communities, schools, families, and children. Behavior modification program, encourage breastfeeding, calculate, plotting, reviewing child or adolescent body mass index percentile at least annually during well child or sick child visit. So whenever you come across a child, check his body mass index, take history. If he's having overweight, counsel them, give them advice not to go to obesity. Type. And as I mentioned at the beginning, the most important rule is 0-1-2-5 in the prevention of obesity. So 0 sugar, 1 hour of physical activity, 2 hours or less of screen time, and 5 or more fruit and vegetables. So you can write in the chat, look for this gross chart. This is an obese child, and you given this gross chart for him, you plot his weight and height. So what do you think? Is this child having a pathological obesity or exogenous obesity? You can write on the chat. So the first response by most of people, they said exogenous. That is good, excellent. And what about this one? What about this one? Is it exogenous or pathological obesity? So most of people are right pathological obesity. This is just simply how useful the gross chart if you plot the weight and the height of the child. Very simple. It can give you a clue about the possible cause of the obesity. طيب, metabolic syndrome, according to the International Diabetes Federations, it's diagnosed for children. Metabolic syndrome is diagnosed for children if the children age between 10 to 16 years have central adiposity and two of the following: triglyceride level, specific levels. So for sure, this is not, you are not going to memorize this. It is available everywhere. You go to Google and write it. It is available. And again, WHO criteria. There is WHO criteria, and there is other classification. But is that just this is two of the classifications. Type take-home message from the obesity presentation: prevention of pediatric obesity by promoting healthful diet, activity, and environment should be the primary goal, as achieving effective, long-standing result with lifestyle modification once obesity occurs, really it is difficult. So you have to work more on the prevention. Comorbidity are common, and screening for it should be applied in a hierarchical, logical manner for early identification before more serious complications happen. And again, 0125, it is a very useful one. Thank you very much for your time. I end the first session of my talk. Then we can move. If there is question, we leave the question to the end. Now we can move to the second part of the talk. Any suggestion, Amir or Dr. Muhammad, or I can move?
Yes, Dr. Bashir, you might proceed to the second section.
Okay, thank you.